Good morning. Thank you for joining early today. We have a fantastic session. I'm delighted to be joined by my co-moderator and good friend, Dr. Khaldoon Alaswad. And this is a really important session, like yesterday's session for perforation. These are essential aspects of what we do in coronary intervention, is to manage complex scenarios and subsets. And calcification and tortuosity are the things that we fear and hesitate, but like all things, patients cannot pick their coronary artery disease and their patterns and shapes, so we have to know really how to manage them. So we have a wonderful panel here, and I'd like them to each introduce themselves, to just tell us where they're from. That'd be great.
Poonam Velagapudi from New York, New Jersey.
Saroj Nupani from Phoenix, Arizona.
Bob Stoller, Dallas, Texas.
I'm Catherine Kunkel. I'm an interventional cardiologist at the Piedmont Heart Institute in Atlanta, Georgia.
Dean Bedulas from Ohio State University in Columbus, Ohio.
All right, and I am Khaldoon Alaswad. I am so proud to have two of the CHIP fellows with me on the podium here. It's like unbelievable. That's gives me a great sense of pride. And the first problem is a balloon uncrossable. This is a very bad problem and vexing, and we have to solve it. And here to show us how to solve it, Konstantinos Charitakis gonna talk to us. Please, the microphone here. There is, that's the microphone there. So it goes like you stand in there. Your slide's gonna come in there. This is how you move the slides, and this is how you point if you want to point. But
thank you.
You're supposed to face the audience.
Thank you. Good morning, everybody, and thank you for the kind invitation here in Denver. And no relative disclosures. So I'm going to present an interesting case of a 75-year-old gentleman. He had class 3 angina, despite max-tolerated medical therapy, and an abnormal stress test in the inferolateral distribution. He had a CABG back in 2004, and he was referred to us from a community hospital where he had a diagnostic angiogram that shows that the SVG to that particular OM branch was down. The RCA was chronically occluded with collaterals from the left system, and the lima to LAD was patent. So they tried to open that OM, and they were unable to. So, there you go. He comes to the lab. We go up via femoral, right femoral, and you see right off the bat where the problem is. You see this, I'll point here. You see the lesion in the OM branch. And for whoever also saw that, that the guide is not very well seated right there. But our lesion is this lesion here in the OM. And I'll show you a couple more images. This is the area caudal, and here you see this specific lesion here. Our guide is still not sitting very well. And one more view. Go back here. Do you mind playing this? Thank you. So we definitely see the guy sitting a little bit better, and this is our lesion here. So I'll be honest that whenever I shoot the diagnostic part of this angiogram, I wasn't particularly impressed. I said, well, this is going to be my plan. I would like to do intravascular imaging and see this lesion a little bit better, but looks a little bit too tight to me. So probably going to try to wire the lesion with a workhorse wire, see how that goes, take it to a balloon, open up the lesion a little bit, and then I'll take my IVUS and go down. And little I knew that the challenges I felt that I was going to face here was at least a moderate distal left main disease, the calcified OM disease that I showed you, and the relative tortuosity from the left main into the OM. And the decisions that I felt that I probably faced was I'm going to have to use atherectomy, rotational, orbital. IVL, and should I do a bifurcation strategy or not? So I said, well, let's just wire the lesion and see how it goes. And this is, you see the problem here we're facing. This is a workhorse BMW wire that went very, very easily, probably fellow wired the lesion. And then initial 2.0 balloon, no way to go. 1.5 balloon, nowhere to go. And this is a 15 millimeters 1.0 sapphire balloon. You can see the guide going back, and it's not crossing. So what do we do now? I would like maybe to open the discussion to our audience. You know, I can definitely recognize some lack of support here. You know, you see the guide going back. What do we do? Do we get a longer guide? Do we do guide liner? What do you guys think?
Thank you so much for presenting this case. It's very, very stimulating, and I will start from like down. But by the way, Arain just joined us. Sal, what's your approach to this problem here?
So first of all, I want to tell Kostas, thank you. You do have support. You have our support. We're here to support you.
Thank you.
So, you know, I think one of the challenges when dealing with lesions like this is the angulations. So while it seems relatively straight in this view, I'm sure if you took some other orthogonal views, you'd find that the wire does not take a very straight course. Also, I see some support issues. The guide is not fully engaged. That often tells you that any pushability is lost because as you push forward, the guide pushes back. Personally, if I see flow, I think there's a channel. I'd probably switch to a torqueable microcatheter at this point, because sometimes the balloon tip is so stiff that it's getting caught in something. And so if you use something like Corsair or Turnpike LP, what you can then do is get past that sort of angulated spicule of calcium and even dilate the channel a bit. So I would try microcatheter first and go from there.
Yeah, you know, the first thing I would probably do is guide extension. I just think the guide support's not giving you much pushability, so I'd probably try that first and just retry your balloons. And then I like the idea as well with a guide extension using a microcatheter, see if you can kind of burrow through that. But I think the first issue is there's not much support. So that's where I would start.
Yeah, I feel this, you know, this had to be an OM1 case. I think of all places in the coronary tree that I hate delivering things that are challenging, it's OM1. So, you know, I think the idea that it looks like you're probably 7 French coming from the groin with a long sheath is a similar choice that I would make. And I think right now, kind of the fork for me is, am I gonna keep trying to persist with balloons, or am I just gonna bail to a drill really quickly? And I think for me, making the decision to move to atherectomy early can save some time in a case like this. And so if I'm really struggling with a small balloon like this, of course, getting a guide extension down to help get your microcatheter across and deliver your wire is really important. But I think for me, the key decision in this moment is persisting or just bailing out to a drill.
I think to that thought process, I agree with you, and I'd like to see an angio with the wire in here to see my wire bias, because the first thing I'm thinking is, if you're not getting a tiny balloon across, I'm going to spin a Turnpike LP across, switch for a rotowire, and I'm going to buzz that. Because like you say, you could spend an hour fighting with this like that, the way you are, or you can spend 10 minutes switching up, putting a burr in, drilling yourself a path. The one thing about this particular lesion is it's that reverse S-shaped sort of bend, and when you take a burr down there, occasionally you can get yourself in trouble with perf or with stall or whatever. So,
Which wire would you use, extra support or floppy?
no, I almost always use floppy.
Okay.
And I do a fair amount of rota, and I don't do much CSI. So yeah, I'd probably switch for a rota floppy, and I'd get after it that way.
Yeah, I think I agree that it needs some form of atherectomy, probably rotational, because you are struggling with one balloon as well. The question is whether you will be able to get the microcatheter across or not. I think if one balloon doesn't go, that's usually a challenge. So adding a guide extension and then following the algorithm, such as like taking this balloon further down. If it doesn't work, do a BAM or something, and see if you can get a microcatheter further down. There are some other microcatheters that you could use to modify the calcium, such as Turnpike Gold, and there's a new microcatheter from Reflow, which also you can modify the calcium to facilitate your exchange. And despite trying all that, if you can't advance a microcatheter for rotawire, yeah, you can potentially do a laser. So you do have a lot of options, but I agree with everybody else. This lesion, you can't balloon and stand. You need to do some form of atherectomy. Question is whether you can do an exchange easily or not.
Poonam, I know, like everybody talked about atherectomy. I'm going to ask you a different question. Would you consider laser in this lesion?
No. I think my first step is I try to get imaging, put a guide liner as deep as I can, and see if I can send a microcatheter and switch it out for a stiff wire. And see if I can do imaging, so that way I have all my support to put an IVUS catheter down. If that doesn't work, I would just take this wire out and free wire with a rota wire and do rotational.
Why not laser?
I think it looks very calcified. It looks calcified, it's tortuous. I mean, what am I going to get? Laser is really not working on the calcium, right? So
Yeah.
I think here it seems like a rota would be the right thing, because the lumen is also very small. I wouldn't even think of shockwave or anything at this point, because this balloon itself is not going. So my bias is to do a rotational atherectomy if I can get an IVUS down or a balloon down.
Saroj?
Yeah, I think the goal of laser is not to modify the calcium. It is severe calcium. Your laser not going to work. If you cannot do a wire exchange before you give up the wire, the laser might modify some plaque and facilitate with the exchange. But I agree, the laser is not going to be good enough to modify this calcium.
Okay, thank you. I think I'm going to move forward for the interest of time. All excellent points, and this is pretty much what we also thought, that it's an easy to wire but tough to pass anything lesion due to tortuosity, as you all mentioned, and likely heavy focal calcification. We also want to do rotational atherectomy, but first we need to exchange a worker's wire with a rota wire. And regarding the additional support, every time we try to push our guide in, ventricularization, drop of blood pressure, and at that time we felt that putting a guide liner in may that left main lesion make the guide liner placement a little bit more challenging. And that's why we have these algorithms. That's a stepwise approach to balloon uncrossable lesion, thanks to Manus Bilakis and his team that published this. That the first technique, small balloon wedge technique, where we go with a small balloon like a 1 or 1.5, kind of longer on the 15 or longer, and then we try to cross. If not, we can go up with that balloon-assisted microdissection. And after that, a bunch of combination for increasing support, wire exchange via microcatheter, and ultimately the kind of atherectomy that most likely the rotational atherectomy. So what do we do here? What do we see? We tried different microcatheters. We got actually, this is the balloon here that we went up to 20, balloon ruptured, no real plaque modification like we did the traditional granuloplasty with a 1.0. As I said, decided against the guide liner due to the left main lesion. We tried the fine cross microcatheter. The Boston rep was there. He brought the links. Like, try this Mamba microcatheter. We tried this Mamba. Mamba went nowhere. And then, what's the next step? Do we change the guide catheter for a more supportive one? Do we use the 7 French system 45, as someone mentioned? Do we first balloon that left main lesion so this way we're able to pass our guide liner? Do we change our microcatheter for a different one? And since we have 4 more minutes, I'm going to move forward a little bit. I heard about the Turnpike, and actually, probably that should have been my first choice. We got the Turnpike, and as you see, Turnpike is down, and we now at this point we feel good. We said, well, we cross with the Turnpike. We're going to put a rotor wire and go through. Well, the little we know that going with the rotor was really challenging. We started like 140. We did 5 passes, and the rotor was not passing. So then there's a 1.5 bear. You know, we up to 180, and then we did 5 more passes, and still wasn't going. And at that time, you know, people in the lab like, well, you know, do we really need to treat this lesion? It's really large amount of ischemia. Everybody was getting like a little bit. We're like, well, let's do one more try. And at that time, you know, finally the rotor passed, and this is how the lesion looked like after, you know, 11 passes of the rotablator. And you know, here then we start delivering balloons. And going back to the algorithm, you know, trying to get more support. You see our guide is already a little bit deeper, but you know, at this point we feel comfortable to, you know, if we need to put a guideliner in, we can. And as you see here, you know, we did have to use a guideliner to deliver, you know, a lesion. So you see that the lesion is not there anymore, but unfortunately the tortuosity is still there. And that make delivery, you know, of the stent, you know, very challenging. So we end up having to use the guideliner, and you know, we started. And then after that, you know, we proceeded with IVUS guided PCI. And as I said, still challenging since we had to deliver to use the guideliner to deliver the OM stent. And here is our IVUS and final steps and final imaging. So a couple more minutes left. You know, the key learnings for the operator and the team from this case, and definitely for me, was a humbling case in the sense of, you know, I felt it was going to be much easier. But you know, you should get all the support you can early. You know, we have an algorithm that, you know, we can use, but for each case we need to individualize. I don't necessarily feel that, you know, you know, we have to decide atherectomy go early. It doesn't have definitely to be like the last part of the algorithm, and definitely all the microcatheters are not the same. We saw that the Mamba fine cross didn't cross, but the Turnpike LP on the same wire did cross the lesion. Questions that we can discuss is, you know, we were already at 10 atherectomy passes. You know, should have tried in 11. In the 11th it went, but you know, would someone have changed the burr side? Would someone have switched to CSI? These were questions that, you know, we're wondering while we were doing the case, and you know, I'm here for questions. Thank you.
Sure. Any questions from the audience? Please feel free to reach for a microphone. I know Manas may have one back there. Thank you for presenting this, you know, super important and very common case. We're going to face this. There are multiple nice, algorithmic, thoughtful ways to approach each step, and that's really the most important thing, is to understand at what point one is getting stuck, and then what each of the maneuvers are to move forward. One thing I have just seen a lot in the last few years is the circumflex. While it's more difficult to see in Amplat's guide, it has markedly changed our ability to do circumflex interventions. And so spending time, we don't often in fellowship see a lot of AL 1.5s and 2s. It's really a great skill, especially if you're worried about a guideliner being a problem. Just having cuss support from an Amplat's guide can really help these circumflexes. I'm not sure if anyone else has any other final comments. It was a nice result. Thank you.
I have so many comments, but we don't have time. No, I would say just a few things. You know, the wire bias issue is an important one, and I think that answers a lot of the questions you asked. So first of all, I think 3 points I'll make is not all microcatheters are the same, and if you use all of them, you'll know why. So I think, you know, I know sometimes they say they're all the same. They're not really. The second issue is CSI, because of its sort of circular action, it's got a nose cone. That would have been difficult to do here. I think Rhoda was the right choice. And then the third issue really is, like, what burr size? And one of the issues with the 125 is that it's very likely to get stuck in places because of the way the back end of the burr is. So 1.5 was the right choice, especially the vessels look big. And the real issue is, you know, how many burrs and speed and all that stuff. But those are my answers to the 3 questions.
The other thing I would say is I never rotablate at 140. I rotablate at 180 all the time. I never pull a 125 burr. And the other thing is you don't necessarily have to cross with your microcatheter. You can get your microcatheter, like you got the sapphire balloon to the ostium of the OM, so you could get the microcatheter for sure to the ostium of the OM, wire the rest of the way with the rotowire. That was a good case. That was well done. And the other thing I would do is if you can't get across with 180, I'd go up to 200. I go up to 200 and buzz with that.
Thank you so much for this case. We'll
Thank
move
you.
forward. Appreciate it. Great job. We'll move on to case number 2, balloon undilatable de novo, the SCAI algorithm, to present by Dr. Ankur Gupta.
So Ankur, the instructions to face the audience.
Okay,
You don't have to look at it.
All right. Thank you for the invite. It's a real pleasure to be here. So this is a 79-year-old gentleman with history of diabetes, traditional cardiovascular risk factors. His echo showed preserved EF normal valve function, and he was having progressive dyspnea on exertion, thought to be inguinal equivalent. We're kind of pushing on the age, but he did end up getting a coronary calcium CTA, and that showed a very high calcium score of 1800, most of which was in LAD, and was read as intermediate mid-LAD stenosis. So these were his coronary angiogram films. No remarkable lesion in right coronary artery, left main, left circumflex, or proximal LAD. On cranial views, you can appreciate that there is a heavily calcified angiographically, mid-LAD stenosis, maybe intermediate, 60 to 70%. So given his symptoms, we did adenosine FFR, which was physiologically significant. So then we switched to a EBU 3.5 guide via radial. This was a JL 3.5 catheter. And then wired the lesion easily with a Minamo guide wire. And then the next thing we do is imaging, and the imaging catheter did not pass. So my question to the audience of the panel is, what do you think when an imaging catheter doesn't pass through a lesion? Does that tell you anything about the lesion or the treatment?
Yeah, so I think that clearly tells you you've got some work to do when the imaging catheter doesn't start. I'm going to be honest, in a lesion like this, I probably honestly would not have tried to image first just because there's so much extensive calcium visible on the angiogram. So in a case like this, where you just see that really solid cast of calcium on both sides of the vessel, I'm generally going with straight in with a workhorse wire, a microcatheter, swapping out to whichever drill wire I'm choosing, and just drilling first, and then imaging second.
Catherine, can you
Totally
tell us?
agree with that.
Yeah, Catherine, can you tell us what made you think it's like, what the criteria in angiography to tell you there is a lot of calcium? What was that?
So, I think you can see there's this dense tract on both sides of the vessel, which I think is an important thing. I think before you inject any dye, even if you have a still frame, you still have a very visible cast of calcium, and that's kind of one of the criteria for severe calcium on angiogram. So I think, this is kind of one of those ones that, I think shockwave in this sort of a case can be maybe a little less satisfying, and I think I'm just going straight with drills on these.
The decision to image to try, I think, is super reasonable. It's fast. You're probably going to pull an imaging catheter no matter what at some point during the case. But as Kate says, if you are stuck, you're going to quickly move to another strategy. I think the question that is it worth doing a partial predilatation to then see if you can image and or deliver an IVL balloon, which otherwise might be very hard. So the question, mechanical atherectomy, then an image and IVL if needed, versus partial predilatation and hopefully image and IVL thereafter are probably the pathways.
I was going to comment. So, great question. So, how do you tell that this is calcium to Cal's point? When you start saying, is that a stent? Are you sure they didn't have a stent before? You know that's calcium. And I think the challenge really is in long tubular calcified lesions like this, IVL is difficult to deliver and somewhat unsatisfactory. I think even if I'm going to do IVL, I would probably take a slightly sort of bigger burr, always use high speeds. In fact, there's an interesting Japanese paper where they actually use both high and low speeds. And there's some evidence that the low speed polishing run behaves a bit like a CSI and has a wider sort of movement and can take out more. So what we do is I start with a 180, I'll make 2 passes with a 180. Once I'm across, I'll do a slow polish with a 140 at a much slower speed to get, but only once though, because it does embolize. And then if need be, I'll use IVUS and then shockwave if I have to.
Yeah, I like the idea that you try to image first, and even though in a still frame, if you see calcium, like you mentioned, that's considered severe calcification, so you can use that criteria on angio. The reason for that is, I've been stuck where you go try to balloon, see if the balloon dilates, even a non-compliant, you're like, okay, my intravascular lithotripsy balloon's gonna pass, but if your imaging shows nodular calcification, not concentric, I've had the balloon get stuck on a ridge, and you know, they're not inexpensive, as you know, and you can't even pass it even though your non-compliant went. So I like the idea that you try to do it, but to be honest with you, looking like this from the get-go, it saves you a hassle just by just putting a burr down.
Can I unpack one question? So a lot of people think, if I dilated with the balloon and I have a dissection, would anybody hesitate after that to do road ablation or CSI?
Unless you have a spiral that's going down the artery, we've done it with a focal dissection, especially if you can't get full balloon dilation. But in this one, this is so calcified from the get-go. I mean, even if you look back at Rotaxis, if you start with rotablator, it saves you half an hour on the case anyway. I'm looking at this thinking, I'm not going to get full stent expansion. I'm not going to get an IVL balloon there. And there's nothing, and we image everything as well, but there's nothing on the imaging up front that's going to change my decision to rotablate. So I'm going to run a 1.5 burr down and image after that.
Yeah, I mean, so
The length is the concern for me here. It's a pretty diffuse, long lesion, right? I mean, I don't know that we could send a good balloon there without getting stuck or, you know, pass it all the way distally. So I think the length is what bothers me here.
so also with dilation, you know, you don't dilate like a maniac, right? There's dilation and there's dilation. Like when should you do OPN? The problem with this one is when dilation goes wrong, it's not the dissection in the lesion. This will not dissect. The dissection will be proximal to the lesion, and you won't be able to wire this lesion again. Or worse, you'll have an avulsion of calcium or rupture that you won't be able to track a balloon or a covered stent down, just because it's like a jigsaw puzzle that comes apart, and when it falls back into place, it doesn't come back the right way. So these perforations are extremely difficult to treat. That's why you don't want to go too crazy on the...
Yeah, excellent discussion, thank you. So I heard from panelists either shockwave or rota shock or combination, so there is probably no right or wrong answer. My personal, what I do in these lesions is I've always been surprised that imaging catheters, they're neither flexible, they're not pushable, there may be support issues, tortuosity issues, so I don't find them reliable to tell me whether balloon will cross or not. So I almost always go with a balloon, at least a semi-compliant balloon. So this was a 2.5 semi-compliant balloon, and obviously that did not expand at all. So in my mind, in my practice, this is what I go through, is that if the lesion is balloon undilatable, is it because of its a fibrotic lesion or the balloon is slipping? Then I use a plaque modifying balloon, like cutting, scoring, or chocolate that can stay there. But if it is purely due to a lesion like this that's calcified, whether I can pass a 2.5 balloon or not, whether it's semi-compliant or NC. If I can pass a balloon, I'm pretty comfortable for most part that I can deliver an intravascular lithotripsy balloon. But if I can't pass a balloon, then I go straight to a atherectomy. So in this case, because I was able to pass the semi-compliant balloon, I went on with a lithotripsy balloon. Obviously needed more support to deliver that with a guide extension. So initially I used a 3.0. I don't have the size of the vessel, but initially used a 3.0 shock wave that ruptured very early, then went on with a 2.5 shock wave that delivered successfully and ablated the lesion. So now I was able to pass the imaging catheter through the lesion, and this is what it showed. You can already see on angiogram just after the lithotripsy that there is a significant modification of the lesion. In interest of time, so these are the still images from the OCT. You can see, is this the point? Okay. So you can see significant calcium fractures at 5 or 6 o'clock with the shift of the plate, and then fractures at 9 o'clock, 11, and 1 o'clock. So the lesion was pretty well modified. This is a 2.5 38 stent based on the distal reference diameter. And this is imaging post-stenting. So I'll just show you the still images of it. So good expansion, some malapposition of the stent. Even the minimal luminal area was 6.2 that needed further expansion. So we post-dilated it with a 275 NC in the distal portion of the stent and a 30 NC in the proximal portion of the stent, and these were the final angiograms results. So again, I go through, if the balloon is slipping or fibrotic, use a plaque-modifying balloon. If otherwise, in a calcified lesion, try to cross it. If I can cross, use a lithotripsy. If I can't cross, I atherectomize. After atherectomy, do an NC post-dil. If the balloon is still incompletely expanded, do additional shockwave lithotripsy. Imaging is really the key in these cases. The pre-PCI imaging I like. To some extent, it tells us about whether we need plaque modification. There are both IVUS and OCT criteria hinging on the size of the calcium, the arc, the length, and its thickness, and presence of calcium nodule. But also, it tells us about what balloon size to use, for example, what shockwave balloon size to use, what's the stent sizing, what's the landing zones. Sometimes we really get surprised the length of the lesion is much longer than appreciated angiographically and change the management plan. During the PCI, after the initial pre-dilatation but before the stenting, it can help confirm adequate plaque modification, and then post-PCI for stent expansion, apposition, and edge dissection. This is a really good paper on the algorithmic approach to balloon undilatable lesions by Dr. Velagapudi and group as reference. So the key points in my mind is that take time to do it right the first time. It's much better to do it the first time right, even leave the lesion alone and bring back the another day, rather than stent it and then having to deal with an underexpanded stent in a calcified lesion. Imaging is the friend, adequate support is important in these cases. Guide size, extension, supportive wire if needed, and then we went over the algorithm. Thank you.
That's great. I think, again, the algorithmic approach is really great, and this is outlined in the SCAI consensus paper for complex PCI if those are looking for another reference. But one of the, I think, things that we also need to emphasize is while rotational atherectomy is absolutely essential, it's such a critical tool, and it really avoids these potentials for overdilatation and dissections as mentioned. There is a real risk of no reflow and perforation, and IVL is clearly safer in this regard. So it is important to sometimes do that balloon test. I think that was well done here. The goal is not to go to 18 ATs and try to dissect, but see if one can get reasonable enough expansion. Because we do have cases, especially in patients who have heart failure or some comorbidities, that no reflow will not be well tolerated. And it's something I think just to weigh every time we're about to pull that drill, which again is essential in certain cases. You cannot avoid using a mechanical atherectomy device. But just wanted to share those comments. One other point about the burst speed is I think it's not wrong to start with a lower speed. That should reduce the risk of no reflow, and some of the references were mentioned that one can get a wider orbit with a slower burst speed. It's also mentioned, and Samin Sharma has a wonderful review in Circ Intervention about the risk of no reflow related to burst speed. So starting with a burst speed with good technique at 150, and if you don't cross, incrementing it is totally reasonable. I just wanted to at least mention that perspective.
Perfect. We move to the next speaker for the interest of time. Thank you, Ankur, for making time for us. Balloon Undilatable was by Evan Shlofmitz. Evan always gives interesting and really enlightening talks. I'm looking forward to his talk.
Thanks so much, Cal. So yeah, as you heard, I was asked to give a case of balloon undilatable in-stent restenosis. So we'll jump into it. Patient with prior bypass had a patent lima to LAD. The native circ, though, had multiple layers of prior stent, and you see there's really multiple areas of in-stent restenosis. Distal left main you have a severe proximal lesion, and you can see there's a little pinch there just past the obtuse marginal. So decide to go in with intravascular ultrasound, figure out what's going on. and really get a better understanding of what the mechanism of disease is. So you see really inadequate lumen areas here until we get to the distal reference where you have an outflow of about 7.5. But what we're seeing here, you see multiple stent layers. You can see in the proximal portion, the stent struts very clearly demonstrated. We have calcium here. Here we have concentric calcium, an extensive plaque in the lesion here with stent under expansion with an MLA of just 1.6. So first step, this is NC. So on the first step was a 3030 NC. This followed by, as you can see, there's inadequate expansion here. So we escalate to a cutting balloon. This is a 3.5 Wolverine at 14 atmospheres there, and you're still not getting adequate expansion. So distally, inadequate expansion. More proximally, we're getting good expansion with the Wolverine. So then escalate to a larger balloon size, and this is 4.0 at 30 atmospheres. So you can see with device detection that you're still having that pinched in segment where the stent strut is. So the more proximal segments, there's good balloon expansion. Here we're not getting, in the more distal lesion, inadequate expansion. So this is the angiogram after pre-dilatation. So decide to go in with intravascular lithotripsy. It was discussed in the last case, IVL versus atherectomy. In this case, obviously, balloons cross, so you know you can deliver an IVL balloon. So a 3.5 C2 plus catheter, deliver 120 pulses throughout the coronary. And there's expansion, but not a perfect result. So here's intravascular ultrasound to see what we have post-IVL. And the problem here was IVUS now wasn't crossing past the bend. Proximally, you see there's good calcium fracture. Proximally, still we have problem if IVUS isn't crossing, it crossed at baseline. One of the issues obviously is catheter fatigue, but because of the multiple bends, wasn't able to deliver IVUS, so we knew we needed more plaque modification. So in this next stage, this was a 4015 NC that went to the high 20s, and before we got to 28 atmospheres, created basically granuloplasty, and the balloon ruptured, and obviously you see some contrast staining here. So the next angiogram, it's a contained perforation. We did achieve dilatation of this undilatable lesion, but I think our options at this point became limited with a contained perforation.
That's fascinating case. We're facing this every day in the cath lab, and of course in a practice like yours, you guys probably see more cases than anybody else. Is it okay to kind of go through the panels and see what their thoughts and ideas at this stage? What we're gonna do, we reached a point where basically we used a high pressure NC balloon and shock waves. What will you guys do? Start from Poonam. What would you do next?
Do you have an imaging, did you put the imaging catheter after this to see how it looked like?
The problem right before it didn't cross. So that was the concern. It didn't cross just before, and the balloon ruptured, which if the balloon's rupturing, it's typically, there's some calcium it's getting hung up on. So the feeling was that unlikely that it was going to be able to deliver at this point, that it needs some additional plaque modification.
Yeah, well, there's two options. I think there's multiple ways to skin a cat. You could just leave this, let it heal, and come back and fix it like you do in a CTO procedure, or try if you can pass a stent and see if you can put another layer of stent there. I don't know that the stent would pass, just given that even your IVUS catheter did not pass.
Yeah, and the main concern because obviously there's still something that's preventing adequate dilatation. The concern, if we deliver a stent, is going to be that stent's probably going to be underexpanded because we really didn't complete the plaque modification at this point.
Poonam just said you could use potentially laser with contrast in situation, but looks like your underexpanded stent is because of calcium. So I would have done IVL like you did also. And after the IVL, you follow the algorithm, high pressure balloon inflation. So our question is what to do next. I have actually started using OPN balloon in ISR cases like this. You obviously want to undersize your balloon a little bit. So I think it looks like your distal reference is 4. That's why you're dilating with 4 and say probably use 3.5 and crank it up to real high pressure. But you just had a granuloroplasty with a perf, so you do have to be aware of that. Like Poonam suggested, there's nothing wrong with this stopping now since they have good flow and bring them back in a few weeks and start over again, unless it doesn't look like it's going to thrombose or anything when you are waiting for next few weeks.
I actually think you're fine right here. You have the whole thing stented already. You could call it a contained perf or a big dissection on the outside of your stents. You actually got the stent dilated. You could make a case that you could do a gentle DCB, get out, see how they do, bring him back if he has problems or more angina or whatever. But I wouldn't want to hammer this again because you run the risk of making it worse if you really pound it at high pressure. But I mean, you have a reasonable lumen, you have the stents open. I don't think it would be unreasonable to either stop and watch it or do DCB here and leave it be and see how he does.
Catherine, what do you think?
Yeah, I'm tapping out at this point. But I think the point is, a 4.0 granatoplasty is a granatoplasty. Whew. So it looks like you actually made a lot of progress with that, even though that's maybe not how you wanted to. So you've definitely modified that vessel. But I think, for me, further high pressure balloon inflations, I think the only thing I may have done differently, because again, I also would not have been fast to drill this, which would have been another option earlier in the algorithm, and you chose a balloon-based strategy, which I also would have done given the tortuosity that you'd have to cross with a rota, is just something I would prefer not to do also. But I may have been a little bit more conservative in my balloon sizing, is the only thing that I would have done differently, but I actually think this looks really good. So I would give protamine and run away very quickly.
Yeah, I couldn't agree more. I would stop. I think you've done a great job. The 4.0 that you used in non-compliant, how high did you go?
It burst in the 20s.
In the 20s, yeah. And yeah, maybe, I don't know, it's maybe a little more aggressive than I would have done, but probably, it's hard to say, but at this stage, I think you've done a pretty great job. Walk away, look the other direction.
Sal, I want to ask a question. I know what you're going to do, but let's kind of a little bit. Will you use CSI, trying to kind of orbit around this and trying to ablate the stent a little bit and see if, like a brick in a washer, trying to beat that calcium outside the stent?
I think that's a great question. Short answer is no. I would consider bypass. No, I'm just kidding. So no, this is great. So this is a great result because my life is committed to stains. I love stains. We have a stain atlas. This is a safe stain. You're in the adventitia of the vessel, you rupture, that's fine, it's not going anywhere, patient's hemodynamically stable, this is okay. The real challenge is that in this type of lesion, you have to think of it this way, that each layer poses a problem. Calcium poses a problem, stent layer 1 poses a problem, neointima poses a problem, stent layer 2 poses a problem, right? And so you sometimes need multiple devices for each layer. So this is not one of those cases where you say, well, I just want to use one strategy and that will work. You just have to crack the code by finding the right strategy. One advantage laser, I think, offers, it's not talked about, this may be sort of my own theory, is that I think laser does heat up stent metal, so sometimes after this, I'll go back with laser, do laser on contrast, and you'll be surprised to find that once you've had this type of a stain, or even if you've done shockwave, that a second time around the stent can expand a bit more. The other way to get to the stent, as Cal pointed out, is to do stent ablation. I use rota for that again because I think there's so much bias that the rota will hit that stent in the right places. And the third thing you can do is actually cutting balloon. And to be honest, we deploy our cutting balloons at 18 atmospheres nominal, and then we go up to 24. So you really have to, but you do it slow. So you get the cutting balloon in there, you get it up to 12 or 14, then slowly dial it up and see if it gives or not. And one last point I'll make is I saw some of your inflations. When the nose of the balloon starts extending way beyond the marker, you know you're reaching the limits of compliance, even if it's a non-compliant balloon. And that's where the granuloplasty is about to happen. And with big balloons, the issue is that the impact is much larger. So, but great case.
Evan, we have 2 minutes. Let's go ahead.
All right.
What did you do?
We weren't done. But, you know, exactly as the panel, I think, explained, I think if we didn't have that prior step of the granuloplasty, our next step in the algorithm, we were preparing to rotor the stent. But at that point, we felt that that was definitely not what we wanted to do, so we went in with laser for the reasons that were just discussed. And then followed it with a DEB so that we can avoid an additional stent layer. And then this is our final IVUS. So we actually, in the more proximal segments, achieved significant improvement in the lumen area. Most distally here, we see there's significant calcium where, you know, unfortunately just wasn't able to achieve optimal expansion, but you know, the more proximal segments, we've significantly increased the inflow. This was just a week and a half ago, so I think a low threshold to potentially bring the patient back, and the next steps will basically be additional IVL or more likely just rotating out the stent if the patient continues to have symptoms, but wanted to allow time just for healing.
And cutting balloon. I mean, cut at high pressures, it really does work, because at those high pressures, those tines will really dig into those struts.
So one of the things I've done with this situation, first, by the way, the OPN is great. You can take it to 45 atmospheres.
Yeah, that's you know, I think another great step.
Yeah.
We don't have OPN on the shelf. We're
Yeah.
awaiting our first delivery, so that'll probably be part of
One of
the
the
next
things,
procedure.
one of the things I've done so far twice, and the third time I failed, is actually I went outside the stent and re-entered right before that area that none expanded, and re-entered right after it, and I crushed it to the side, and I stented a new, just created a new pathway. And there are multiple ways to exit. Like sometimes you can do in-stent power knuckle, or you take your confianza, stick outside, then go to knuckling. You knuckle past that area and you re-enter. That's one of the thing, which is similar situation I had to deal with, and that's what I did.
So if you were going to rota this, would you go 1.5? Would you go 1.75? What would be your approach if you were going to rotablate this?
1.5. I wouldn't do anything smaller. I think it's going to be more
I
likely
wouldn't
it
go
gets
smaller.
in trap. But you know, I think you just need to get some plaque modification here, and you're not trying to remove the entire stent, but you know, right here, you need to modify this calcium. It looks like there's calcium inside the stent strut, so this is calcific neoatherosclerosis. More than likely, you're not going to get the burr and trap, but just being able to create some calcium fractures and thin out the calcium should help. Then we'd probably follow it up with an IVL or an OPN if we have it available at the time.
Use of laser was great. I just had some questions about you know, when you use that in the algorithm. You know, should one use it before one gets super, super high pressure? But even including the OPN, I think is an open question. And then the size of the laser. It's quite possible with a 1.7, which is totally a reasonable size for the overall vessel, that it may have been hard to actually get it into the most tightest part of that lesion down here in segment D, where the MLA is just 2. So, you know, is there a value to stepwise approaching? So starting with the 0.9 to really get that buried inside that zone, and then and your comments about doing this with saline versus contrast versus full contrast.
Yeah, so for ISR, we're using contrast. The impact of it, I'm not really sure. You know, I think we have limited data on its impact on in-stent restenosis, so it's something that we're evaluating just prospectively in a registry. So I'm not sure. You know, there's certainly a lot of debate on what the impact is, but I think in ISR with contrast, it's a safe modality that is effective at some sort of plaque modification. It typically is in conjunction with additional steps. It's typically not adequate on its own.
It's dirty though. I mean, so the dirtiest thing you can do is like IVL with contrast, because you can't predict how much trauma you're going to cause. Sorry, not IVL, laser with contrast, yeah. IVL is cleanest because you can kind of monitor, you see, you can go high pressures. Granular pressure is less predictable, but with IVL, we've had cases we've done IVL and laser, and then you see the entire calcified vessel floating in this adventitial sort of hematoma there. So laser can be quite traumatic.
Great, thank you so much, Evan. Great case, appreciate it. Thank you. We'll move on to case number 4, calcified nodule, another really important subset. So much has been learned in this area in the last several years. both mechanistically and then practically. Dr. Yader Sandoval will illuminate further.
Good morning, everybody. Thank you to the panelists, organizers for having me here. Good morning. All right, so let's get to it. Calcified nodule. Actually, I see a number of my colleagues that I think a number of us were involved in this case. So this is a 65-year-old frail female with unstable angina, chest discomfort on and off for the past couple of months. Morbid obesity, as you can see, with a BMI of 47, HFpEF hypertension, CKD, preserved TF. Referred in this context for a coronary angiogram. This is the diagnostic coronary angiography. And as you can see, there's a severe ostial proximal LAD and a severe distal right coronary artery lesion. At this particular point, the case was stopped. They did a heart team approach. And as you can see, the patient was determined to be at high risk for surgical interventions, STS of 12, and surgery. The surgical team was particularly very hesitant of a surgical approach given the morbid obesity and limited mobility, so they favored a PCI strategy. Comes to one of my colleagues, not me first yet, and so this is actually not the case of interest, but it actually, I think, would be worth discussing when you see this in one lesion, whether this applies to another lesion. So they first tackled the right coronary artery lesion, and as you can see, there was a total challenge with engaging this right coronary artery. Ultimately, they were able to engage it with a JR4, required deep guide liner, balloon undilatable lesion. They were able to expand it, but ruptured. And as you can see here in the subsequent slide, you can see that this was a very calcific lesion, large perforation, sealed with 2 papyrus stents. So I'm not yet involved in the case, but I'm seeing all of this. So now they asked me a few days later, tackle the LAD. So this is the LAD, and I think this is the crux of the discussion, and I'll shift it to the panel soon. This is what we're now asked to do in a stage LAD PCI based on all the context that I just told you all, guys, and I will ask you all to look at the IVUS carefully. So this is the severe osteo-LAD, and of course the question is, what are we seeing there in the LAD and what should we tackle? And maybe I'll push it back to the panel unless you guys want me to keep going.
All right, so this is a very interesting image and common problem in the cath lab. And this is, can you start from Sal there? What's your thoughts, what you're seeing, and how would you approach it?
No, I'll keep it brief. I think this is a tough location for calcified nodules because this is where the risk of in-stent restenosis is the highest. I mean, I'm not sure I have a good solution for such calcified nodules because it's not just one nodule, it's the entire bifurcation of the left main that's calcified, and that calcium nodule really has nowhere to go. Having said that, if I can do atherectomy, I prefer that because I think that cleaves the nodule, and then I'll follow it with a shock wave. So that would probably be my strategy.
So Dean, atherectomy obviously, would you do CSI or rotablation?
Well, given the fact that we only do rotablation in our institution, that's what we have on the shelf, I would do roto. And I'll tell you what, I mentioned this previous, the nodular calcium, I think is where you, not particularly for this case, is where you can get stuck with your intravascular lithotripsy. Even if you can pass a 2.5, which the algorithm showed earlier, or even a 3.0 not compliant, I've had the IVL balloons get stuck on those ridges, and you're not able to use it. So I would just go straight to roto with this. And it is at the bifurcation, but the ostium at the left circ is not really involved, so I wouldn't be too concerned about that. Yeah.
Catherine, I want to ask you an additional question. Is this eruptive or uneruptive nodule? And would that change your approach? And would you start with shockwave or rota? Or
Can I phone a friend to Evan?
Yeah.
No, so, in terms of, I don't pretend to be an expert on eruptive versus non-eruptive nodules, but this certainly looks quite chronic and stable. I actually did a super similar lesion this week, and I called it a retroflex LAD with, again, one of these nodules. I'm doing CSI for this sort of thing, for better or worse. I think, for me, my concern with the tortuosity is, and maybe this is my skill with the drill, but I'm going to have a jump at some point in the case, and I would prefer that to be backwards. I find my control with CSI a little better. So I'm in this sort of a lesion, would love to say I would get this with just a drill, but honestly, probably I would be taking a CSI distal to the lesion, treating it backwards, doing, you know, a half dozen runs. I tend to not go on high speed with this much tortuosity when you have the kind of the LAD folding backwards like that. So for that reason, I accept the fact that I will probably need to do shockwave after atherectomy. But that's just how I take
Robert,
tackle
how
this.
would you approach this? How, like,
So this one, I would probably put a 7 French guide in, and I would probably go with a 175 burr. Honestly, it's a big artery. I want to make sure I get
what
some
speed? 182? 175
Yeah,
and 180?
I start with everything at 180. I've been doing it for a long time.
And a
That's what I'm
floppy
used
wire.
to. And I wrote a floppy wire, and I would try to buzz through the proximal and make contact, you know, the best I can with the nodule, come back, and then I would probably try an appropriately sized cutting balloon at 18 or 20 atmospheres and see if it dilates at that point. And if it doesn't dilate at that point, I might try IVL. The problem with these is they're not so satisfying to treat because nothing works really perfectly, and I don't think any of us know really what the best strategy is. But I would try to debulk it to the extent I could and use a calcium modifying device after.
So Roj, I'm not sure if we were working together or with a different, when you were a fellow, very eccentric calcified nodule in the proximal LAD. The CSI ripped the LAD open in my cath lab, and that patient didn't do well. And so I'm always kind of leery about that. How do you approach that? And this is a calcified nodule at a critical location, and like, let's see what you're. What do you do?
I agree. I think the atherectomy in combination with IVL, ROTA versus CSI, my concern with the ROTA and this is like lumen still seems to be big enough so that if you use a smaller balloon, it will just do, smaller burr, it will just pass and do nothing. Even 175, I'm not sure you'll get enough plug modification. If you look at the ostium, it looks like unless wire bias is favorable, except the very ostium part of the LAD, the wire bias doesn't seem to be favorable. I personally use CSI, probably forward motion and low speed, come back, treat high speed right where the ostium and combine with IVL. But like you said, we know the limitation of atherectomy. In cases like this, you can do atherectomy, which may not do anything, eccentric calcification like that. And then with the IVL, we have some data that nodule can be modified with IVL, but we're not going to get perfect result even with the IVL in cases like this. So probably need combination of both, but I personally use CSI with IVL.
Poonam, this is like there is some data about IVL, right? It's like it is just like Ziad Ali published it, and it works. So the question I have for you: will you start with IVL or with atherectomy?
I was actually going to say that maybe I would have started with an IVL. First off, I don't think the IVUS is good enough to tell us whether it's eruptive or not. Maybe OCT would be a better technique to tell whether it's an eruptive or non-eruptive. And then there is some data from Ziad, as you mentioned, that it may work better with one kind versus the other, and the way it's eccentric. So I think I would wire it and try a high pressure NC, and then try the IVL first, and if it yields, it's great. I'm not having to do ROTA. And also there's some ectasia, I think, in the proximal vessel. I'm not going to try and get such a big lumen. I'm going to try and get a decent lumen, but I'm not going to really, I think there's a ectasia, or it's turned on, it's on itself, bent on itself, that vessel in the, just distal to the lesion.
Great. Why don't you tell us what you did?
Great discussion. I think it really illustrates two things: the inter-operator variability. And I can tell you, when I was putting my slides and I was looking at the case, since I had not looked at it in a couple of months, I thought, oh, why did I do that? Like different approaches, because I think it illustrates I don't know that there's a right or wrong. There are different ways to do things. Evan, are you there? Evan, can I put you in the spot? Eruptive versus non-eruptive. I think the question that Cal asked here, it's critical, and I see you there, so I think it would be great if you can comment on that.
I agree with what everyone's been saying. In the beginning, it's definitely, the proximal portion is definitely not eruptive. There's some irregularity as you get more into this. So this is protruding nodule, it's non-eruptive, but right here, oftentimes there's, if you see with OCT, you can really see the cap and you can see that potentially it's eruptive. I think the reality is with these, there's still some debate on the best management. You need to modify it. As soon as you inflate with a balloon, you're gonna figure out whether it's deformable or not. Because of the wire bias, I agree, CSI, I think orbital atherectomy, you could use that to your advantage. You see the IVUS catheter is abutting the nodule, which means when you replace the catheter with a 125 crown, it's gonna start to modify that. And typically I would do orbital atherectomy and follow it with IVL. It's protruding into the lumen. So calcium, you're going to see the bright white on the ultrasound, but here you see something's actually going into the lumen. So things that protrude into the lumen as opposed to the wall, it's either thrombus or calcified nodule. That's it. And here you see it's bright white, that same white arc that you normally see in the wall of the vessel where it looks like calcium. There's acoustic shadowing behind it. So you get all this dropout that's black beyond it. But there's portions where it actually is going in the lumen. It's no longer on the outside of the circle, but hold on, here's, I'll show you where it comes up in 1 second. So there it's protruding in the lumen. You have a little bit from 7 to 10 o'clock. And now this is all sticking right there. It's sticking into the lumen. So anytime you have a protrusion in the lumen that arises from a base of calcium's calcified nodule, if you think it's thrombus, take a balloon at 10 atmospheres and you're going to see whether it deforms it or if you have underexpansion.
Yeah, I just wonder about potential risk of CSI when you have no calcium on the other side. And from my reading, I haven't done it, from my reading, that tends to be a risk factor for dissection or even perf if you have cal bias. I see people saying no, or at least motioning no, but that's what I've read, is that the risk is greater with CSI when you have no calcium on the opposite side.
So I fortunately haven't run into that. I think bad things in CSI don't tend to happen on low speed. If they are going to happen, they're going to happen on high speed. So I think, with a calcified nodule and a little bit higher risk anatomy, I tend to be, and it's very against our tendency as an interventional cardiologist to go very, very slowly over the nodule with the burr, but I fortunately have not run into this, and I pretty routinely use this for calcified nodules. There's no speed, it's just low or high. Yeah, so I just stick on the low speed, yep, and just spend a lot of time on the nodule.
Let me show you the...
Yeah, please go ahead and
let me show you the resolution here. So we had all these thoughts. I will add just a couple of comments. One is the issue, I think, of wire bias and the vessel size that you pointed, I think, was in our mind here. And this issue of eruptive versus non-eruptive, I think it's something that we as a community need to further emphasize a little bit more. So we're thinking about all these options. We've discussed about this at length. So in this particular case, we started with intravascular lithotripsy. And our thought is, particularly this issue, it's a huge vessel. How do we make sure that we make contact with the nodule? We're aware of the very interesting data that CVI has with OCT, so we went with a well-sized IVL balloon, 4012. Afterwards, we did a Wolverine, 4015. Actually expanded very nicely, both of them. You can see there's a dissection now in the proximal LAD after the cutting balloon, but we feel that we've made some reasonable modification here after both the IVL and the cutting balloon. And subsequently, we go ahead and do a 4022, and then, 3534 in the LAD, and then a 4022 with a pot at 5.5 into the left main, actually with pretty good expansion, and we're very happy with the result. I'll see if I can play this thing here. You see, I think we got a pretty solid result. You'll see the IVUS on the right. This is pre-pod, so we did optimize the left main. That you'll see it's under expanded. But I do want to highlight, particularly in this next run, how the nodule looks pre and how the nodule looks post. And I think the point is here, and again, this is pre-pot, but you can see the nodule pushing the stent. And I think that the issue is that, this is the area that I think we need more data to understand whether this is where you in the future could have ISR or stent thrombosis despite having a good area, but you can clearly see still the nodules pushing against the stent. The stent is overall otherwise well expanded. So I will wrap it up and point you, I think this is a wonderful review, was just published this year by CVI and a number of colleagues in JACC. It's just a review on calcific nodule, and this issue of eruptive versus non-eruptive calcified nodule, I think it's something that we need to further emphasize, because as you can see, the thought is that if you have an eruptive calcified nodule, as shown on the left, which is more that irregular disrupted fibrous gap, this is the one that you just thought that to be deformable, such as in this case, whereas if you have a non-eruptive nodule, that's the one that has shown on the right on the bottom of the OCT, that's the one that on occasion can be non-deformable and actually, maybe trickier to treat. So hopefully that will be my message to differentiate that. Thank you so much.
Really great. I think one of the things that also is individualized is the patient risk. So while we really embrace a lot of atherectomy devices, IVL is incredibly safe, as you demonstrated here. And so this case is a surgical turn down, most likely. If there was truly an emergency, you're going to be in a difficult position. So sometimes trying a safer option, I think if you have an IVL approach and it doesn't expand, then you're fine with going forward with doing something mechanical. Great case. We'll finish up.
Yes. I wonder, Bob, if we're going to have a directional coronary atherectomy for the calcified nodule. Anyways, just kind of thoughts. The next speaker is actually a friend of mine, and he's going to nobody better than him to talking about tortuous artery. Bob Stoller.
Okay. So 82-year-old man, hypertension, hyperlipidemia, chronic kidney disease, interstitial lung disease, heart failure, and aortic stenosis, the cases that all of you guys treat every day. Cabbage in 01, Lehman to the LAD in three veins, multiple PCIs the last 7 years ago, admitted to Baylor, excuse me, with respiratory failure, BiPAP, elevated troponin, EF of 20. All of his vein grafts are occluded. He's got in-stent restenosis in the circ, and he's got this. So as you look at it, he's got two problems in his Lehman to the LAD. One that's up top, right where you put the catheter in, and one right at the bottom where it anastomoses to the LAD, and it collateralizes the right coronary. So any thoughts about this from you guys?
Yeah, I would start with nitro first. Make sure it's not spasm where the catheter.
This is after nitro.
Yeah.
That's a very smart, good thought, though.
And then you have like the stenosis is really in significant locations where at the anastomosis where the risk of rupture is the highest. Obviously, have to deal with it, have to fix it. So I would start with putting a good wire down, ballooning the osteal lesion, and then go down and balloon the distal lesion. Well, it sounds easy, but obviously you have to be careful. A question I have for you is, did you use a support, impella support, or not?
Okay, so
it seems like a valid reason to use.
That would be the next question. Saroj, we'll start from you.
Do you have an angio of left system? Because sometimes
the left system, I didn't put it in here. I have too many others, but there's in-stent restenosis of the circumflex, which supplies a big OM. The osteal LAD is occluded, and obviously the osteal right's occluded. So all you have from the left system is a circumflex and a flush occluded LAD at the ostium.
And what's the ejection fraction? I'm sorry.
20.
Yeah. So anybody would fix native LAD here? Native LAD.
Yeah.
It's a super important point. Salman, but
I was going to make that point. So, okay, so when you deal with these last remaining vessel type of situations, sometimes if the patient is stable, it's better to disconnect the artery so that there's less risk. So the lima may shut down, but if the circ and the prox LAD and the RC are doing their own thing, you're less likely to have an issue. So I would probably favor fixing the native LAD or attempting the native LAD before doing this. And it's not the ostium that we're worried about. It's that touchdown where you have that little kink in the lima. So again, it's not the touchdown itself, but there's that hazy kind of zone right across the lima, and that's the tortuosity there. And that's where oftentimes these will spasm.
Yeah, I would assess the possibility of CTO, PCI, LAD. I would like to look at the left coronary system first before I decide to intervene on this. The couple things, if you're going to intervene on Lima, so tortuous, after you put a wire bias, probably no flow going into the RCA as well as the LAD, somebody low EF. If we're going to fix the Lima, I would definitely put in a support, I think. But I would actually CTO PCI may be safer in this case. So depending on the angio, which we don't have, but I would strongly consider opening native LAD.
Yeah.
Catherine?
On a 1 to really hard scale, I think this CTO is not going to be easy. You know, you're dealing with going through a flush occlusion, you've got stents to cross, you've got extensive calcification. Now you're going to be, you know, doing a reverse cart, hopefully somewhere in the proximal LAD, but you have this circ system you're going to protect. You also have a really sick patient right now, right? They're hypoxic, their EF is 20%, they're really sick. So my approach here is you need to survive, not you, me, the patient, we need to survive to fight another day. So I think doing kind of an ad hoc, really hard CTO PCI is probably not what I would do right here. I would be ballooning and probably stenting the osteal lima, and I would be trying to balloon and not stent the insertion site, and planning for a CTO procedure, perhaps with support, when you have a more stable patient.
Yeah, let's say you're going to tackle this and just forget the native. If I was going to do this, what I'm worried about is when you wire this, and you mentioned it, the tortuosity, you may kink and decrease flow to your LAD, which is essentially supplying, 2/3 of your myocardium. So I would do this with support, but I wouldn't do it with Impella. I'd do this with ECMO support. I would place, and we've done a handful of these, and they work out well. Support the patient, because if something goes south, and even if they go into arrhythmias or cardiac arrest, your Impella is not gonna help you. So that's the way I would approach it in the controlled environment.
Okay, so.
Well, this is a fantastic discussion and super important case. Just to make sure that we reviewed it, the LAD target is so good that is this a case that you should consider a redo bypass if they became clinically more stable?
So his creatinine is 2.5. He's been on BiPAP and nearly intubated. His EF is 20. He's got interstitial lung disease. I think on the scale of 1 to 1,000, the surgeons will go 1,000-fold the opposite way to never touch him again.
So it's clear when there are surgical turn down, this is obviously the PCI focus, but it is really important to.
That's a reasonable.
When the LAD is a good target, I think, and the Lima's failed, it's worthwhile considering that. Secondly, just the range of mechanical support is a super important conversation. Another potential opportunity is to use something between a Impella CP and ECMO, which is the Impella 5.5 surgically. Has your institution adopted that in some such situations?
We have them occasionally. Generally for that, we're going to need the vascular guys to cut down for us, or that's our practice generally.
One of the things against the Impella in this patient, he's going to have biventricular failure once you start working on the Lima, if you start working on the Lima and shut it. So the Impella will compound the RV failure, will make it actually worse. So I go with Dean on ECMO on this patient.
Okay, so I'm going to flip through a few of the things I was going to talk about. Tortuosity is a predictor of not doing so well in terms of TLR. Whichever stent you use does worse in tortuosity. So what I decided to do with this guy, or generally in tortuosity, for left-sided things, consider 7 French, avoid your Judkins, use an EBU or an XB, use an aggressive guide on the right, AL guides are good. No real good options for guide in the IMA. Think guide extension if you need them. I try a workhorse first. And then if you need, you can move to hydrophilic wires. But remember, when you use a hydrophilic wire, you increase your risk of dissection, potentially in perf. In terms of delivering equipment, you may need shorter, non-compliant balloons, stiffer wires. Use your guide liners, telescope if you need to. I generally try not to rota in tortuosity. And I work distal to proximal. And remember, after you put your stent in, you need to look at your wired vessel compared to a pre-wiring image of your vessel to look for wire artifact, or what we call pseudo lesions. So here's your ostium wired. I actually decided in this case, I put an Impella CP in him. I actually went out and talked to the family first, left him on the table, put an Impella in, used a microcatheter, a Turnpike LP, wired it with my workhorse. I worked distal to proximal, dilated it with a 2.5 balloon, no problem delivering, getting better. I put a 3.015 DES there because this was going to be probably my last shot at getting him, as sick as he was, to be fixed all the way. And we're making progress. I didn't lose the antegrade branch. So at this point, I IVUS almost everything, essentially everything. But in this tortuous vessel in the lima, I'm standing there thinking, okay, I've delivered a stent, I'm in good shape, he's tolerating it well, the last thing I want to do is tear the distal lima. So I'm just going to forego IVUS in this case. I took a short post-ill balloon, a 3.25 by 8, hammered it to make sure it was well opposed. Said, okay, I'm enormously happy with that. We're making progress. Let's move to the proximal lesion. I put a 3.012 in at about 12 atmospheres, pulled the balloon back, post-dilated that at about 15 atmospheres. Hemos didn't budge with the Impella in place. Took a look at that and said, I think that's about as good as it's going to get. So that's our final angio without the wire, and you can see our wire bias at the distal lima went away. And here's my final angio of the entire lima to the LAD with the collaterals preserved to the right, Impella in place, and that's how we finished up. Got out of the lab in one piece.
Amazing case, amazing, and good. And it actually brings a lot of questions about what would you do next now. So, would anybody now stage opening? Of course, the circ you treat it, right? But also, if you're going to treat the circ, is it disingenuous to treat the circ and treat the RCA? What's the thoughts of the panel here on completeness of revascularization or not?
I mean, he's in a good situation, right? So we know that fixing those vessels is not going to improve the EF anymore. PCI for recovery of EF in stable patients doesn't work. We did this so they wouldn't get worse and to resolve the acute ischemia that he has when he exerts himself. So for me, I'd be happy with this situation. This is a great result. And honestly speaking, when I talked about doing the CTO, there's no penalty to pay because you're not injecting it. And if it doesn't work, then you go down this route. So even if your CTO chance is 5%. But since I think that ship has sailed, I'd be pretty happy with this.
All right, for the interest of time, I think we should move.
Great. Thank you so much. Great case, Bob.
Thank you.
Okay, on to our final case presentation of the session. Case number 6, supercalcium. And we're going to be informed. Thank you so much for coming up, Dr. Alaiti.
Thank you very much. Okay, so I have a case of 87-year-old male with past medical history of hypertension. He has refractory angina. He had a heart cath that showed 3-vessel disease and was turned down for a surgery. The plan was to see if he would respond to medical management, but he didn't. He was very symptomatic, almost like resting angina. His EF is 55%, no valvular disease. And this is we're going to focus on the left system just for the sake of time. But you can see that there is severe amount of calcification with the angulated lesion here in the LAD, as well as in the circ, severe calcification with severe disease. So obviously you need to be prepared for these cases. If the plan is for PCI, then how would you approach it? The first question, despite a normal EF, would you use MCS? Would you go with atherectomy? And any concerns? I'd like to ask the panel.
Okay, let's start from Dean. He's volunteering.
Yeah, I would. Looks like I didn't catch what you said that LV slug function was, but it looks like the arteries are moving, so I probably would not use a support. Again, you said EF was normal preserved?
EF 55%.
I would not, and I would do atherectomy. Questions getting your wire there. The one thing that, and it was mentioned earlier on the panel that I have found it helpful, if you can't get your wire, if you can even jam the nose of a microcatheter or balloon to the tip, you can actually, it's worked, it's bailed me out in the past where then you can actually pass your wire, and you may have to do it with this because the image on the left looks like it's squeaky tight.
Yeah, I agree. I also would not use support in this case up front. I think I check an LV EDP at the beginning of all these cases, so I'm assuming that wasn't something. I think most of the stable outpatients do okay. The thing that I'm struggling with is which lesion I would go after first. I think wiring that LAD might be hard. I think for me, the unpredictable piece of this case, and that's kind of where I focus what my worries, is where can I not predict how something's going to go. I don't know how wiring that LAD is going to go. And so in that case, I'd often start with the other vessel. But my struggle here is where am I going to land my circ stent, right? If there's one stent that I think I'm going to safely land in a vessel, that LAD, it looks like you've got a nice landing zone. And so the circ, maybe not once you get in there on IVUS. So I think my initial thoughts on this is I would have some worry about shutting down the LAD with wiring. And if and when that happens, I want an open circumflex, especially as you mentioned, there's also right disease. So I think I would probably start with the circumflex, but with the idea that I may also have to come back at the end of the case and then extend a second stent into the left main, depending on what the os of the circumflex looks like after dealing with the LAD second.
I'm sorry, I missed the first part because I was coming back up. Is this patient definitely non-surgical? Not to be the heretic in the room, but is there no bypass? Is there a bypass option for this patient?
It was discussed. I mean, he's 87, but I think, to be honest, he was good 87, but he was seen by multiple.
He's 87?
He's 87.
Okay, well that
But he was
makes
seen by
him
multiple surgeons, and the decision was no for cabbage, and we even went with medical management to see if that would be sufficient before we proceed with, and it wasn't.
Okay, yeah, I wouldn't support this guy. I would be inclined probably to do I tend to do the worst or whatever first, and the biggest territory is going to be the LAD. And if for some reason, if cabbage is not an absolute prohibited situation in him, if for some reason you really can't get through and you can't get it opened up or whatever, you could still potentially put a lima on him and a vein on the OM. But I think you're going to be able to rotablate both of these and dilate them and expand them, and I think he's going to do fine, and I don't think he's going to need support, personally.
Yeah, I agree. No support. I'll probably fix the LAD. It just looks like there may be a landing zone, so try not to balloon back to the left main, and if you have a landing zone, stent the LAD and then wire the circ and fix that, because I'm concerned that your circ stent might need to come back to the left main. Just based on angio, obviously we don't have IVUS, we decide how to stent based on your IVUS findings, obviously, but it's just a wild guess, I guess, in terms of stenting. But because looking at the angio, that I'm hopeful that I might be able to just stent the just the lesion in the LAD and then finish the circ and then figure out how to treat the distal left main bifurcation into the circ, whether you need to stent one stent based on your IVUS findings. If you need additional calcium modification at the ostium of the circ or ostium of the LAD, you can always use IPL, but looks like both of them need rotational atherectomy.
Yeah, my first glance at this, the left main looks almost the size of the LAD. just that ostial proximal. So obviously I want to take a good look at that with an IVUS. And as one of our panelists earlier mentioned, I think if he's a candidate for bypass, he's got great targets, so I would obviously go that route. And the second thing I notice is that the LAD is like really supplying a very large territory. It goes all the way back. So if this patient were to have a complication or something, or if the LAD were to go down, it's going to be very catastrophic. So I think I'm going to be very prudent about at least fixing about the left main into the LAD, and then decide about, once you have imaging, maybe a bifurcation into the left circ based on how the disease looks.
There's a comment from the audience.
Thanks, Cal. So in our center now, actually one option that we offer to these patients, because of age, he's 87, but maybe not quite for a full bypass, is mid-cap for Lima to LAD to take care of the worst kind of vessel situation and then do a stent for the others. I was just wondering from the room, what is your experience in your centers? Do you have surgeons doing mid-cap? And nowadays they start doing actually robotic mid-cap, so that saves us from many patients, give the third option really.
Yeah, that's actually an excellent point. The hybrid approach, I think, is actually it's a good one, and we do a handful of those with lateral thoracotomy on pump. It depends on the thoracic cage, how big it is. With the surgeon can see it lean into robotics, so that's actually a good point that you bring up.
Okay, so thank you so much, all great comments. And I would add to that my concern was actually that the left main does not look totally normal. And add to that is this ectasia and the aortic root and the guide, position. This is like struggling to even get there. This is a diagnostic image. So yes, my plan was to image the left main to make sure to understand if this is significant or not, and maybe tackle the CERC first. So we did wire the CERC. I did elect for impella. I do believe that, if it's not only EF or LVEDP would dictate, but, complexity of anatomy. And obviously, if the patient was unstable, you do mechanical support. But if he becomes unstable during the procedure, that's where you need it, and then things can become, a little bit hectic. So yeah, wiring the CERC was very easy. The LAD was very difficult for the points that everybody mentioned. Angulated lesion, they kept biasing into the septal branch. You cannot find a good view where you can tackle the angulation and avoid the septal at the same time. We didn't use, supercross. I used LP catheter, but I like to avoid hydrophilic wires. But I just kind of tested, the Xi'an blue just to kind of see if it helps. It didn't. And then I moved on quickly to Xi'an black I used first. Run through Xi'an black, but then Xi'an blue. I thought you need actually less hydrophilic wire, and you need to be able to torque it and direct it. And that's actually did the trick, but it did take half an hour. So my plan was initially to kind of wire both and maybe image and then tackle the CERC first, but because it took half an hour to wire the LAD, we kind of went with the LAD first. And this was as teaching institution also before I moved to private practice, so that time was, part of it. So
can I ask a quick question?
Yeah.
So once you have the impella in, you're committed to doing both, right? You're
Yes.
going to do both the LAD and the CERC, I would think,
Correct.
since you've got large bore access.
Now-
I'm just curious from the rest of the crew, how many of you in an 87-year-old would stage this, would do one at a time versus doing them all at the same time? I think they're both good answers. I'm just curious from...
I'm a huge lover of staging these things. I think it's easier on the patient. It's definitely easier on me and the team. But I think the reason that I would be worried in this one I couldn't is because of that left main. Yeah. It's when everything's all attached to each other at the trunk, I think you're forced.
I agree with
and
that
I
too.
think just this is a case where I would lie to myself and say I want to just do one, and then I would be
And you
doing
may
the
not
second
be able
vessel,
to.
the same procedure.
And that's exactly the thought process, that whenever there's a concern about left main, I think, you need to keep that in mind, and that's why the support up front, but it gets a little bit more complicated. So there is guy.
Amer, we can hear, you need to talk to the audience. Okay. Just kind of,
Yes.
They are their audience.
Yes, just the light and the face. So, what do you see? It gets really complicated here. That There is left main dissection, and we haven't even started with the plan that everybody agreed that this is need atherectomy. So, and just to kind of point out, I wanted longer guide up front. I wanted 8 French, we didn't have it. This is 7 French XB4. I didn't have any longer one, but I was worried about this up front. And I mentioned this from the diagnostic cath. So obviously this is guide-induced dissection. But I did have the wire through the LAD now. Anybody would continue to proceed, and what would you worry about? Audience?
No, like you did the right thing. You need road ablation, you use road ablation.
One thing is just you can try to, once at least the rotabur is partially in the left main before you turn it on, you can try to adjust your guide so you're not angulated right towards that cap ulcer. And just try to de-stress it.
Yeah, and you can see, good point. You can see we try to do that. The problem is obviously, advancing equipment keeps moving, So it's obviously you should have perfect guide, in my opinion. So, but you cannot abort at this point. So we keep going, but went in with the rotablator, activated after the dissection, and just kept in mind that I would want to minimize angiogram and injections and things like that, and wash the patient hemodynamically. So we did 6 runs of atherectomy. Patient remained stable. And to be honest, as soon as we finished the atherectomy of the LAD, his resting angina actually completely disappeared. He told me, like, at this point, that he feels a lot better. So that was a good sign. But the question is, and I actually did, this is not to kind of recommend using OCT in this scenario. Maybe you can use IVUS, especially if you are an IVUS operator. I did use 7 French tap liner, and that's another thing that actually can make things worse, but also wanted to kind of facilitate delivery of equipment in case things get worse really quickly. But having the imaging kind of help prepare for the next step, which is stenting. In my opinion, if the patient become unstable, you need to commit to stenting the LAD into the left main. Right?
Just warning for the audience, once you have a dissection in left main, you should never inject again. This is like OCT is not because you could propagate that dissection down the LAD and down the circ, and you're going to lose both. So, but this is a heavily calcified vessel, so that's why, it's less likely, because as if it's stented with calcium, it's less likely to cause that problem.
100%. I mean, I would say you should avoid it, and if you can continue without any injection whatsoever and only IVUS, I think you should. But this was done, extreme caution. The question is what to do about the circ. Would you just now stent left main into the LAD and get done? Or would you consider, because you're gonna jail it, which is okay. I think you're okay just to jail it and forget and treat medical management for the circ. But would anybody tackle the circ at this point? And does it need atherectomy? It does look like it needs atherectomy. Anybody from the audience?
So I would shockwave the circ now. So now at this point in time, you're in a stable position. I would never give up this LAD wire until a stent is to the osteal left main. But I think you probably could wire the circ, get the expansion on the circ, and then do a culotte of your, from the LAD to the osteal left main, treating your circumflex as kind of the second leg of your culotte. So that's kind of how I would shift is I say, okay, I've got priorities here. Left main LAD is my priority, but I'm not willing to give up on all this circumflex quite yet. So I would just shift my stent strategy and my order of my bifurcation stents to kind of take that dissection into account.
I want to ask you a more basic question. So you want to wire the circ first. Which wire would you take? Would you take polymer jacketed, workhorse wire? Which kind of wire, knowing that you have a left main dissection?
So I'm taking a workhorse. The other issue here is that I love a guide extension, but it's going to start hurting you as you're starting to try to add another wire around. So I might consider pulling the guide extension now. And I'm going with a workhorse, not a jacketed wire. I think jacketed wires might make things worse.
I'm going to differ a little bit, and I think we've already, the dissection is extending all the way into the LAD, you already damaged one vessel. I mean, I wouldn't want to cause trouble to the other vessel here. I would, as quickly as possible, because you're injecting, I would hate to inject, I think as quickly as possible, stent that left main into the LAD to prevent further extension. It's a very big LAD. You don't want it to extend down because it's all tortuous, and it's just, I would stent it and then bring him back on another day for the circ.
I agree with you, Poonam, because the dissection is already, like the wire was past the dissection. So in fact, if you couldn't wire the circ, if you stent it, you may actually tack up the dissection and be able to wire it. So I agree with you. Because we are actually 5 minutes over time, we're going to move fast.
Yeah, so I'll tell you what happened. Obviously, all of these, I totally agree. You should not give up, in an ideal situation, do not give up the LAD position. But just because I did have the OCT and I know how extensive the, or was not extensive dissection, it was actually really localized to the left main and a little bit into the LAD, but the rest of the LAD is really good. I felt comfortable actually just proceeding with the circ atherectomy and just landing a stent into the ostial circ, proximal circ, 3.0 stent post-dilated 3.5. And then I had my OCT done, which helped me a lot plan what stent and what size and what's post-dil. So basically, one stent left main into the LAD, obviously pre-dilated 3.5, the stent is 3.5 by 38 to cover the whole segment that was intended to be treated, post-dilated with 3.5 and 4.0 NC. And that's the final results here.
So Amer, did you pull the wire from the LAD when you, so why didn't you just put a stent in the LAD all the way to the ostium, not stent it, so you can actually guarantee that you will be able, at least, just in case, because you got lucky, the vessel didn't shut down, and I think the OCT helped you decide that. But in a situation like this, why risk it? Why don't we just put a stent all the way to the ostial LAD and put a good stent, optimize it, and then you can pull your wire. You don't have to kind of burr along the other wire.
Yeah.
Yeah.
No.
Yeah. I think it's just too much at stake. I wouldn't have done that. I think, like Cal said, you probably got lucky. A patient did fine and with a good outcome. But I wouldn't have done that. I would probably just stent back to all the way to the ostium with the left main. Let's say you can always come back and jailbreak the stent and rota or whatever you need to do. The circ, if you are worried about, protect the left main with the guide extension when you bring him back. But yeah, I wouldn't have given up the wire without stenting the LAD.
Yeah, I would for sure not have given up the wire if I, just relying on angio. Maybe you can use IVIS, but OCT helped a lot. Doing that one OCT run, which I know is kind of risky, but helped a lot understanding what I can do next. And the thought process was the dissection is localized. And back to your question, if you land at the ostial LAD, then I would have obviously abort the next step of atherectomy because we cannot land things perfectly at the ostium, and then I have to overlap with another stent in the left main. So that was the thought process. So
you don't have to line it perfectly. All what you need to do to protect that LAD from collapsing. So you can bring it at, you can leave 3 to 4 millimeter because you absolutely have a great wiring skill. So if the LED is not going to shut down, but if it shuts down, you'll be able to wire it a lot easier.
I think you can also put a microcatheter on that LAD wire and then rota into the circ and just kind of change the location. That also is possible without taking the wire out if that's absolutely what you want to do.
Yeah, for that, I think they need 8 French, but he started with 7 French guide, so I don't think that was an option in his case, but yeah.
Okay, so any comments from the audience? Any question? Okay, thank you very much. So basically, this is just all the points we talked about. Be prepared. I think mechanical support up front kind of helped, continue the case. So thank you very much. Thank you so much.
Great presentation. Thank you. And thank you all for attending today. Have a great rest of your day.